oblique palsy. So firstly, I will give small introduction about superior oblique palsy. After that, we will present the case and take home messages and lessons learned. زي ما احنا عارفين السوبيريور oblique palsy one of the most common vertical paralytic strabismus. It can present whether unilaterally or bilaterally, and the bilateral form may be symmetrical or asymmetrical. And occasionally signs of SOP develop in the contralateral eye after the surgery. يعني مريض جاءك بunilateral superior oblique palsy وبعد ما عملت العملية المريض ظهر بsigns of contralateral superior oblique palsy وهذه الحالة بنسميها masked bilateral superior oblique palsy. Incidence of masked bilateral superior oblique palsy reported to be between 10% and 30% of the unilateral superior oblique palsy. 10 إلى 30% من الحالات اللي جاءوا للعيادة على أساس إنهم unilateral superior oblique palsy بعد ما نعمل العملية طبعا الفولو اب يختلف بعد ممكن post op day 1 post op 2 weeks 2 months 3 months even years after the first surgery he can present with contralateral superior oblique palsy. Patient with a masked bilateral superior palsy initially show no clinical signs of bilaterality يعني ما فيش reversal of hypertropia ما فيش excyclotorsion في الother eye ما فيش reversal of hypertropia في الهيد tilt. This case 50-year-old male known case of benign prostatic hyperplasia on tamsulosin. Past ophthalmic history, he had bilateral cataract surgery, bilateral phacoemulsification 1 year ago, and history of head trauma more than 10 years ago. Complaint of binocular vertical diplopia around 8 months. أنا اعتقاد إن المريض عنده ديبلوبيا قبل كده بكثير ولكن بعد ما عمل البايلاترال كاتراكت سيرجري والنظر يتحسن في العينين بدأ يلاحظ الديبلوبيا. The uncorrected visual acuity was 618 plus in the right eye and left eye. The best corrected 612 plus in the right and 69 in the left. Anterior segment examination bilateral, quiet pseudophakia, IUL in place. Posterior segment examination healthy, posterior segment with right fundus extorsion, which is one of the confirming signs that the patient is having right superior oblique palsy. So this is the motility examination. Patient has unmaintained fixation in the right eye. Cover test at near and distance. Patient is having exotropia 20 to 25 prism diopters and R by L 30 to 35 prism diopter. Right, very large right hypertrophy, 30 prism diopter. And inferior oblique over action plus 3, superior oblique under action minus 3 in the right eye. So أي حد هتجيله هذه الحالة, this is pure unilateral superior oblique palsy with large right hypertrophy, 30 to 35 prism diopter. This is the preoperative 9-gaze photo of the patient. Patient is having right hypertropia, right inferior oblique over action, and right superior oblique under action. That is the preoperative primary position. So the surgical planning, because this is a large hypertropia, 30 prism diopter. So if I did only one muscle, that will not correct the full deviation. So I have to do 2 muscles. Usually inferior oblique alone will correct up to 15 prism diopter, nothing more than that. So I need to do 2 muscles. So usually we do intraoperative force duction test. If the patient is having tight superior rectus in the same eye, then I will do right inferior oblique recession with superior rectus recession. But if FDT is negative, then I will do inferior oblique recession and contralateral inferior rectus recession. And that is the case of my patient. He had FDT negative for superior rectus. So I did right inferior oblique weakening with left inferior rectus recession. Post-operative follow-up, post-op day 1, small exophoria, no diplopia. Post-op 2 weeks, exophoria small, no diplopia, happy patient, happy doctor. This is post-op 2 weeks. Patient is orthotropic, no problems. Then what happened? Post-op 2 months, patient came with left hypertropia, 10 prism diopter, occasional binocular vertical diplopia. That is the measurements. And also patient had left limitation of depression. So this is the 9-gaze photo after 2 months of the first surgery. Left hypertropia. So we shifted from right to left hypertropia with left inferior oblique overaction. And also left limited depression because of the inferior rectus recession that done. So the surgical plan for the second surgery was left inferior rectus advancement with left inferior oblique Parks recession. So follow-up post-op day 1, patient has small exophoria with R by L2 prism diopter, no diplopia post-op 2 months, patient still only small exophoria and no diplopia. That is the patient after the second surgery. He is orthotropic with no diplopia. So that is the summary of the case. Firstly, right hypertropia, then left hypertropia, then finally, alhamdulillah, patient is ortho. So take-home messages: in cases of superior oblique palsy, always check for signs of bilaterality. Superior oblique palsy, difficult to detect before surgical correction of the initial manifest palsy. MPSOP is clinically quite prevalent. Dr. Kushner reported 8 to 28% of the cases of unilateral SOP will manifest with bilateral masked suboblique palsy, and always inform the patient preoperatively that the patient may need second surgery. Any patient with vertical strabismus, especially superior oblique palsy, I usually tell them that there is a chance that we will need to take him back to the operation theater almost 50%. فهذا المريض انا كنت عامل له كونسلنج كويس، جاي له ان احتمال كبير نحتاج نعمل عمليه ثانيه، فكان المريض متقبل الموضوع بشكل كبير الحمد لله. When the contralateral palsy becomes manifest, ocular alignment can usually be restored with a simple and effective secondary operation. هذه سلايد بس بنتكلم فيها عن preoperative signs of bilateral superior oblique palsy, reversal of hypertrophy in any of the oblique fields of gaze, subjective extorsion more than 10 degrees, V pattern, especially V pattern esotropia, and chin down posture rather than head tilt, bilateral fundus extorsion, and small hypertrophy in primary position with large hypertropia on ipsilateral head tilt, and reversal of the hypertropia with head tilt to the contralateral side. Thank you.